Thank you for joining us on this webinar hosted by Waterlase MG with our special speaker, Dr. Ben Curtis. Dr. Ben Curtis is one of our key opinion leaders for Waterlase MG and is a pioneer in the pediatric world. Um, Very awesome guy. We will be doing Q&A after the webinar, so please add your questions as Dr. Curtis is doing his presentation. That way we can do Q&A about 10 to 15 minutes before the webinar ends. Okay, so with all due, Dr. Curtis, you are up.
All right, guys, thank y'all for joining in. Today, we're going to talk about tongue tie successes with the Waterlase laser. And kind of first off here, who am I? Oh, well, I'm a dad. So these are my four kiddos here, and my wife, Rachel. So we have been married 15 years this month, and these are our four little kiddos. So this is keeps me going here. We live out in East Texas, and so we're out there on a cattle ranch outside of Dallas. We're about hour and a half out, and I serve on our local school board out there in the middle of nowhere. So we're busy with family things and stuff like that. My wife drank all the Disney punch, so she's always trying to find ways to get us to go to Disney. When you got four kids, nobody wants you but Disney. Not even Walmart wants you there. I did my dental school at Mother Baylor in Dallas, Texas, and this is one of my good friends from dental school. This is us on injection day. You'll notice that there's red in the syringe down there. That was his first injection and maybe one of his last because now he's an orthodontist. I did my residency at Mother Baylor as well, so I'm inbred. I had the great privilege to be able to stay and do my training there. I am a diplomat for the American Board of Pediatric Dentistry, and this is Laurie Johnson and I doing a talk at a conference during COVID. So those were great mask times for sure. I'm the past president for the Southwestern Society of Pediatric Dentistry. If you're looking for a great conference to come to, the ski meeting they do every year is pretty epic. So you need to look that up, put that on your calendar for February. I am a past Harris Fellow for the American Academy of Pediatric Dentistry, and I did my research project with the late, great Dr. Susie Seal. If you knew her, you loved her. And if you knew her, it was a great privilege you had to know her. I'm in private practice. I'm a private practice guy out in East Texas. My private practice is in a small rural area that draws from a much larger rural area. My patients will drive an hour, 2 hours, some even 3 hours to come see us. And right down the road from us is this little farm area where they've got like carnival rides and stuff. And they shoot off these cannons that are filled with candy every weekend, and it's pretty impressive. Of course, the cannon's not filled with, chocolates. It's filled with like Starbursts and Warheads, all the stuff that gets stuck in your teeth. So there's plenty of carries in these candies to go around. This is my team right here. We're nobody in private practice without our team, and so they are the ones that make all the magic happen. I'm just the chaos coordinator. I love to do these educational things, and I love partnering with Biolace to be able to get you this information. So we'll give a big shout out for Biolace for putting this together tonight, and I hope this really is worthwhile for your time. So what we're going to talk about first is kind of identifying different ways that you could release a tongue tie, then kind of walking step by step through that release specifically with the Waterlase laser, and then looking at what the benefits are for the Waterlase laser for the tissue, for the patient, and for the provider. So we're going to kind of all tie that up together. But first, why do I care about a tongue tie? Okay, I feel like that's a solid question. Okay, well, let's think about it for the kid. Okay, for this kid specifically. So, this kid's not able to lift his tongue up at all. It's not necessarily that he's got severe speech issues, but definitely he just doesn't have a great range of motion. That can create a lot of tension in other places. It can create speech and airway issues, and it can really just create quality of life issues and the lack of feeling normal. A lot of our patients will report that they just feel like they can't do certain things with their tongue when they become of age and be able to have those higher cognitive levels of thinking. And so we really want to think about for these tissue attachments, what's the problem now and kind of what could be these problems for them. This is a case that I did with the Waterlase laser, and this is immediately post-release on the bottom left, and then on the bottom right, that is a 1 week heal. And so definitely that's something where these are the kind of cases that we're thinking about for our older kids. Babies, there's a lot of going on with breastfeeding and bottle feeding issues, and pacifiers are now a thing. It's kind of like a workout piece of equipment for them. So there's a lot going on as far as oral anatomy and oral function and all as it relates to infants that really hasn't even been something that's been on our minds as pediatric dentists in the past 10 years, but it's really come to the forefront for a lot of places. And we are one of those that serves our rural community. This is a baby here that was in our community that every time she ate, her stomach swelled up so large. I mean, this is her immediately after she eats, and that is not full of anything other than air. She was so dysfunctional in feeding, she couldn't gain weight. She screamed all the time, and the pediatrician was about to admit her to the ICU so that she could get a feeding tube put in. We released her tongue attachment, and immediately afterwards, she was able to eat without bloating. This is not every case out there, but this is one of those cases that really you made a strong impact for that kid and that family with a simple procedure, and a procedure that I use the Waterlase laser for. If you haven't read the autobiography of Benjamin Franklin, it's a great read. And I definitely think that there's some great strong points out of there. And one of the things that Benjamin Franklin teaches us is without continual growth and progress, such words as improvement, achievement, and success have no meaning. He also tells us that well done is better than well said. So we have to keep pushing forward to make improvements for our patients and our community, but we can't just learn it. We've got to put it into action. And so you are called to action because in the world of seeing children, the American Academy of Pediatric Dentistry calls us the big authority on little teeth. But I would challenge that logic and say we're the big authority on little mouths. We own the mouth, not just the teeth, and the tongue lives within the mouth. There's many different ways to get the job done when it comes to a lingual frenectomy. So let's kind of take a look at maybe some of those different ways. The old tried and true original kind of way of doing this really was more with scissors, okay? Not a pair of scissors for fabric cutting or paper cutting, but your little surgical scissors. And not that those don't do a fine job. Research shows us that done properly, the procedure will have a good outcome. But there are pros and cons to the different ways of doing the procedure. And a lot of practitioners these days don't feel as comfortable with scissors because you don't have the precision and control that a laser provides for you. In the laser realm, there are so many different types of lasers. If you've had to vet the lasers and look at all of them, if you're at the American Academy of Pediatric Dentistry's annual session this week, there'll be many, many lasers that they have on the showroom floor. And I would challenge you to go look at all those lasers and to go by and look at the Biolase booth and give it a whirl. If you've already using a Biolase Waterlase laser, then you really know kind of some of those differences and why you chose yours. The diode laser is more of an old school way of doing a frenectomy, and not that it doesn't do it well. And it has many functions, not just in the frenectomy world, but it's more kind of like a hot paper clip when it comes to soft tissue procedures and not as delicate as some of these other lasers are. And so the diode laser kind of falls out of favor as it looks at infant frenectomies and things like that. It has a lot of great functions outside of the use of soft tissue procedures as well. And so there's multifunctional type of things that we can use with a diode laser. CO2 lasers are quite popular on the market. There's CO2 lasers that are soft tissue only lasers, and those are ones that are, quite popular for frenectomies, okay? But when we're utilizing a soft tissue laser that is only for soft tissue, you're really kind of not able to do as many other procedures that you might be able to do if you had an all tissue laser that could do both hard tissue and soft tissue. So you are kind of limiting yourself quite a bit in investing in just a soft tissue laser. There are CO2 lasers that are all tissue lasers that will do both soft tissue and hard tissue as well. And we're going to compare some of those directly to the Waterlase and how they interact with the tissue as well, because the tissue interaction is one of the biggest differences that we can see between them. And we have the different erbiums, and the Waterlase is an erbium YSGG laser, and it does soft tissue and hard tissue as well. And it's wonderful at doing fillings and removing caries. It's attracted to the water and can be a great adjunct for caries removal without having to do an injection. That can revolutionize the pediatric practice just in hard tissue treatments there alone. But I really love it for my soft tissue patients. And one of the things that I have found is that a lot of the lactation consultants in my area had been used to working with people that utilize CO2 lasers, and they can distinctively see a difference in how less discomfort my babies have and my patients have, how better they heal and all. And I would chalk a lot of that up to the Waterlase laser. So let's look a little bit more at exactly what is a frenectomy. If we're going to be talking about tongue ties and releasing those, here's a great before and after picture. In a simplistic world, what we're looking at is basically you're just cutting the tongue where you're sending the tongue up and the flora mouth down. In this before picture on the left here, we're seeing that the salivary glands are getting pulled up out of the floor of the mouth. We make a release through that. Now the salivary glands relax and go downward. An excellent pre and post-op release. But what exactly is this tissue? That's a great thing to be thinking about. So what exactly are we cutting through? One of the most recent anatomical articles released, and comes from the Journal of Clinical Anatomy in 2019 by Nikki Mills. Nikki Mills is an anatomist out of New Zealand and released this landmark article that really helped change the way we look at the frenum tissue and helped us better understand what exactly we're cutting through. What she did was she went and looked at cadavers, and she basically changed the dogma from just releasing the buccal mucosa to releasing the buccal mucosa and the fascia. So you are releasing through the fascia, and the fascia in this picture, as we see, is what holds the body together. It's all the webbing that is in there. So when we're releasing a frenum in a patient, we're releasing the soft tissue buccal mucosa or outer mucosal layer under the tongue, and we're also going to be releasing the fascia that attaches through that. So what exactly problem solving are we doing here? A major concept that we always want to have in mind when we're looking at doing a tongue tie release and diagnosing a tongue tie is we want to be putting together these few simple facts and establishing these and documenting them as well to help indicate a procedure. We want to be looking at the patient's symptoms. We want to be adding those together with the function and the functional issues that we may be having, and also what the anatomy looks like. And when we add those three together, that should help us establish an indication for a procedure. If we have anatomy without functional issues or symptomatic issues, that doesn't give you a solid indication for a procedure outside of a plastic surgery type thing. And I mean, plastic surgery has its case as well, but that will help us as we logically work through those as well if we focus on those topics, okay? Let's think about more of an old school modality for releasing those. As we mentioned, scissors, scalpels, blades, things like that definitely were the only way to get those done for many years until laser technology really revolutionized things. When I was finishing up my residency and going into private practice, I called up one of my buddies that was in oral surgery residency and asked him, how do y'all do frenectomies as oral surgeons? How are y'all trained to do them? And he said, well, we put the patient to sleep. We put a throat pack in. We put a strong suture at the tip of the tongue, lift it up, clamp it with hemostats, and cut that out, then suture it right back up. That's the classic Z-plasty type way of doing a frenectomy, and that's what we're seeing here, where you put the suture at the end of the tip of the tongue to have good control of it. You will release and cut out that tissue, and then you'll put some good strong sutures in there to suture it back up. That's the traditional modality for a releasing, but is that the only way to do it, or is that wrong? That's really not a wrong way to do it. It still works quite well, but we have to ask ourselves, who wants to sign up for that? Is that what the parent wants their child to have? Is that what the referring office wants the procedure to entail? Or are there more minimally invasive, less aggressive ways than having to put the patient to sleep, cut out the frenum tissue, and suture it back together? And here comes lasers for the answer. Okay. Definitely the new school way does not entail all of those things. And definitely this is where patient acceptance is a lot greater when we can have a more minimally invasive sort of thing. Referral definitely will like a less invasive way of doing it. And the versatility that comes with the Waterlase laser allows you to do soft tissue procedures in addition to hard tissue. So the versatility for you in a dental office setting is a lot higher than what it might be if you were an only soft tissue provider like an ENT. Well, what is the laser? Okay, well, this is what we're looking at. These were the fun wraps that you used to could get with these. A laser is just a fancy flashlight. That's how I describe it to my patients and parents all the time. We're just using a fancy flashlight. Well, how does it work? It's attracted to water. So different lasers are attracted to different things. The diode lasers, as we see here on these funny little squiggle graphs, diode is attracted to blood. But the erbium laser, the one that we're utilizing, the erbium YSGG laser, is attracted to both tooth enamel and the water in that. If you'll look at this too, as you move farther out in your nanometers, the CO2 laser is also exceedingly attracted to water. And that's why those are the two lasers that are the most popular on the market for soft tissue, because soft tissue is made mostly of water. So this laser loves water. So what does it do to that? It actually vaporizes it. Okay, that's kind of a crazy way to think about it. The fancy way of calling it is soft tissue ablation. Okay, but it heats the water up and it basically makes everything just disappear. Okay. There's actually a lovely little write up about it in the AAPD reference manual that talks a little bit more about those things. So if you got that, they mail it to the members of the American Academy of Pediatric Dentistry every year, their updated reference manuals. So you can go check it out and read about lasers in there. How do lasers benefit the tissue? This is one of my favorite slides. It's kind of weird to think about that necrosis might be one of your favorite slides. But what this is showing us is how minimally invasive this laser is. And so the Waterlase laser only affects about 5 to 10 cell layers of depth. So if you had an onion, theoretically, we're only cutting through about 5 to 10 cell layers when you make an incision. The scalpel cuts through about 100 to 300 cell layers, and all of those cell layers will be traumatized. They'll have to go down the inflammatory cascade. Yeah, think back to biochemistry, okay? And on that cascade is pain, inflammation, potential scarring. All of those sorts of things get induced the more necrotic or the more damage that we have to those tissues, the more they turn over. And so the Waterlase laser is very, very kind to the tissue. That means it's very minimally invasive. You get less bleeding, less post-op inflammation, less pain and discomfort. And to this, I credit why my babies do so well with these procedures. They are not upset and crying afterwards. They are able to nurse and feed and everything totally fine immediately after the procedure's over. Let's compare it to some of the different types of lasers on the market in a diagram here, okay? What we're looking at for a diode gets a bad rap because it burns the tissue and you get a zone of necrosis, of carbonization around there that actually looks like a burn, okay? It kind of looks like a cigarette burn. Not very great for a parent to be looking at. It's very, you have to prep them for that to let them know that's okay. A CO2 laser works very, very fast, but if you don't work fast, you will definitely overheat the tissue as well. And you're going to get a nice white zone of necrosis as opposed to the dark zone of necrosis that you will get with the diode. You'll also notice with CO2 and diode that you tend to get more of this foul odor of burning flesh. You don't get that with our erbium laser. That's definitely one thing that parents normally always report if they've had another older child that had the procedure done at another office with another laser is that, oh, that did not smell as horrible as it did with our older sibling because the laser is not burning the tissue. It keeps it very cool. And that's what we're looking at here in this diagram. When we're looking at heat, CO2 has a lot of heat that it utilizes, and it can heat the tissues up to over 500 degrees Celsius. The Waterlase laser with the water off, if you turned it completely off, still only will heat it up to 85 degrees Celsius with the water on, which we do recommend. it will be only 14 degrees Celsius. That is very cool. It's not enough to burn the tissue. Okay. And one thing that I'm noticing in my patient population, as we can see in the bottom diagram here, that most of my patients are healing at about 2 weeks, where with other lasers, it's expected to be 3 to 4 weeks. And I would say my lactation consultants and therapists that I work with would definitely say that they can feel that as well, that our laser just heals quicker and better with our procedures. Here's another view of kind of comparing an erbium laser to a diode laser. You can see that dark carbonization, but you can also see that white ring around it. You tend to get that white ring with CO2 lasers as well, but with the erbium laser, it's just a straight incision, okay? One of the things I really love about this laser too is it feels very familiar in your hand. It's designed to be like a contra-angled high-speed handpiece. It's got a little laser tip that goes in it that's interchangeable. It's got a light. It sprays water. It has an aiming beam. It just feels very familiar to what a high-speed handpiece would feel like to us as dentists. The tip on it is very burr-like, but we are not going to be touching the tissue, okay? It is not a burr, although it does feel like it's a burr. We're actually going to be hovering about a millimeter away from the tissue, and that is our precision zone, okay? And that is the zone of destruction is only about a millimeter. That's actually a safety feature as well, because if you're 3 millimeters away from the tissue, nothing happens. You have to be 1 millimeter away to actually make the laser have an effect, even if it's firing. So I love that feature for babies. Sometimes when they move, it's not going to actually make an incision unless I am constantly holding it there at that 1 millimeter. And it helps me just have more brushstroke control. The different types of tips you use matter. So if you are a current Waterlase user, you understand that there are many different types of tips that you can utilize, just like you can use different types of burr in the end of your high-speed handpiece to accomplish different goals. There's different types of tips that you can use. There's cylindrical tips, there's chisel tips, there's bigger tips, and there's smaller tips. There's reusable tips, and there's single-use tips. There's many, many different kinds. But these are my favorite kind of go-to tips is the MZ5 and the MZ6 tip, okay? For soft tissue, I love this MZ5, MZ6. Other friends of mine really love the MC3 sapphire chisel tip, and you can actually contact the tissue with that, and that kind of feels like a blade. And it is reusable for that. So some people really love that laser for frenectomies. Once again, my favorite is kind of the MZ56 and the MZ66. They're just kind of a versatile workhorse for both hard tissue and soft tissue. So what does all this laser stuff mean for the patient? It just means it's super safe, super minimally invasive, and definitely something that is making it a lot easier these days to have the procedure done. A lot of times I don't need my 4-year-old patient to sit still for anything more than 5 minutes and I can have the whole thing done. And that's a game changer. We know with a little nitrous, we can get kids to do a lot of things. So let's walk through a step-by-step kind of situation here. If you take away anything from this lecture tonight, I want us to be taking away the fact that we need to be taking before pictures and after pictures, okay? Here's a great before and after. And sometimes it's nice to have a couple of different angles here, but what we can see here is a short frenum that's having a hard time elevating. Just the tip barely comes up. Afterwards, we can see how nicely this tongue elevates completely. And even the little diamond-shaped area is closing on its own almost completely with elevation. And there's very, very minimal bleeding, okay? How do we control the infant? This is always a great question I get. I love to have a stabilization board that sits in my lap, and I like to sit knee to knee style, and I like to swaddle the baby up. I'm old school. I love those really big muslin blankets, and you fold it into kind of a V, and you lay the child there and swaddle them up. I swaddle all my babies up like that, and we utilize our baby swaddles in there. And the parents are always so impressed how well I can swaddle up a baby. But I love the swaddle blankets, but there's many different types of swaddles you can utilize. Okay. As I mentioned, I love a good lap exam style. I don't really like for the baby to be laying on the chair, on the dental chair. I like for their head to be in my lap, sitting in the assistant's lap. Okay. You can do one assistant or two assistants, but the doctor definitely is at 12 o'clock. You need another assistant at 6 o'clock holding, and you could have a second assistant if you wanted, kind of out to the side at 3 o'clock that can be suctioning or passing you things. How do we control that tongue? Great question. It's not the easiest. Old school is the suture and lifting the tongue. New school is a groove director. You can get a metal groove director on Amazon for super cheap. They make bamboo bamboo wooden ones. They make autoclavable plastic ones that are my favorite. I love those. The plastic ones are just a little softer. These metal ones can be a little firm. You just put it under that tongue and you lift it up. And this is a great example of a picture here where you're isolating that frenum and lifting up the tongue. That way you're protecting the base of the tongue and you're guiding your release. So this little instrument is cheap, simple, and great for the procedure. Do we numb? This is always a great question that I get. And a lot of this comes down to your preference as the provider. But what do? I don't numb. Babies, we really don't want to be using benzocaine on any infants, okay? Anyone under 12 months for sure, because with those topicals or injectables, we can have an increased risk for methemoglobinemia, which is a rare delayed reaction that you can have to topicals or to benzocaines and prilocaines, and where the baby will turn blue and stop breathing. And so we want to have a healthy respect for our anesthetics in these young populations because you can have things like methemoglobinemia that can occur. The FDA does have a black box warning under the age of 2 for benzocaines. And so we just want to make sure that we are taking that into consideration in the pros and cons when we're utilizing things. Okay. And that, for one reason, is why I don't like to utilize any sort of topical anesthetics. What about lidocaine? FDA does not recommend for it to be used on infants under the age of 6 months due to the same risk for methemoglobinemia. Okay. And you can find those sorts of things on the FDA's website. Okay. So I don't do any injections. Okay. For my infants, if you're under 12 months, we are doing these procedure, quote unquote, clean. Okay. I find that it's a very simple, short procedure, like ripping a band-aid off, and then the baby's back up, happy again, and they're fine within just a minute or two after the procedure. Most parents are able to feed the baby immediately afterwards without any sort of post-op issues. For my older kiddos, I love a good compounded topical. If you're able to order the best topical ever, that's the name of it. It really is the best topical ever. Texas has weird pharmacy and prescription laws where we cannot import things from other states that aren't made within the state. I don't know, it gets weird. So we can't order the best topical ever. But if you can, you should look it up because it's really great. But a lot of times you're able to do these soft tissue procedures on older kids without having to do any injections and just use a strong compounded topical over the area. Okay. So before we use any sort of anesthetics or local anesthesia, topicals, anything like that, just consider the risks there for your patient and the pros and cons for you as the provider and the patient. What's the difference between a child procedure and a baby procedure? Well, first, there's no swaddle. They should be able to sit still for it. And a little nitrous and sitting still, it works great. I do like to numb my older kiddos, okay? And I love a little compounded topical, a tiny little bit of local into the area. I find that they don't feel it, but it helps the procedure just go a lot faster. You don't have to wait 10 minutes for pulpal anesthetic because it's not in the pulp that we're working, it's in soft tissue. So you instantly deliver that local anesthetic, just a little bulbous, and then away you go. Okay. And so that can really help. The other difference is yeah, they got teeth in there. So you just got to be careful if you're doing those toddlers. Okay. Let's dive into a lingual frenectomy here. Okay. The first question I always thought, or when I was starting these, it was a great question is, well, where do I even start with this procedure? Where do I go? And so, I mean, these frenums come in all sizes, shapes, everything. So, kind of, where is a great global place to kind of get started? Okay. I like to make a horizontal incision as I'm making my first cut, and I like it to be below the groove director, but above the salivary gland nodules. Okay. You want to have your anatomy in mind and your anatomy in mind as you make your incisions. That's one of the things I really love about this laser is it is not like super fast, like done. It is nice brush strokes that allow you to be able to keep a clean surgical field while maintaining good anatomical identification. The most important thing about any surgical procedure is making sure you can identify the anatomy in your surgical field and you're making proper incisions. And so I love that this laser has such great control and precision for us as the doctor so that we can make the appropriate incisions. Okay. We definitely want to make sure we're being very careful. Some providers like to make an incision right at the base of the mandible. I don't really like to do that because you're getting a no man's land really quick. And I have seen some cases where they've made incisions into the salivary glands by accident. And so we really want to be mindful of the salivary glands, okay? Not just your vessels, okay? Mindful of the salivary glands. Well, the next question is if that's where I start, where do I stop? Well, that's not always the easiest question to answer either because every mouth is different. Okay. What we do know is that we want to make sure, once again, if we think back to what is a frenectomy in a nutshell, it is filleting the tongue off the floor of the mouth. So we want to make sure that we're getting those salivary glands down and the base of the tongue upward. Okay. And we want to do a nice finger sweep when we're done so that we can make sure there's no additional posterior pressure there and that we have a nice little diamond shape where the fascia has been nicely removed. Okay. The other thing that we're also looking for is that they should be able to elevate that tongue, particularly a child that has good tongue control, that's been working through speech therapy, myofunctional therapy, should be able to lift that tongue up and make a good tongue suction or elevation. Okay. And so those are great things to be looking for as we're looking at where to stop that incision. Okay. Big thing I would always like to caution people is it's not a race, okay? A 10-second frenectomy is no better than a 60-second frenectomy if both of them achieve the job, okay? I like to take it slow, I like to take it simple, and it still doesn't take me very long to get these done. We always want to keep our landmarks in mind. Clean and clear surgical sites, okay? For our child frenectomy, once again, I really like this example because you can see preoperatively, this child's making an excellent tongue suction on the roof of their mouth. So we can clearly see where we can make that functional release. We want to make it superior to those salivary glands, but inferior to the base of the tongue. So the groove director can help us isolate that tongue base better, and we can make that lateral back and forth movement to get the tongue to go up and to get the salivary glands to go down. Okay. Same thing here. This is a 60-second procedure, doesn't have to be 10 seconds. Okay. If we keep a nice, clean surgical field, we'll be able to see where we start and where we finish. Okay. Let's take a look through an infant frenectomy case. So a little different here because they're smaller. You know, you don't have all the teeth in there, and it's a lot of a smaller space to work with. So sometimes this can be more intimidating for providers because it's a smaller patient. But positioned properly, suctioning properly, all of those things can make this procedure go much more smoother and predictable for you. We can see here that this baby is trying to elevate that tongue up, and you can actually see how the frenum attach is all the way to the tip of the tongue. Okay, so we would call this a full anterior attachment and a very short one at that. So these can be a little tricky, particularly if you didn't have a groove director. But as we lift that tongue up with the groove director, we can see nicely where our frenum is, and we can make a small release. What I always recommend too is to make an incision and stop. Reassess your surgical site, lift it up again, make an incision and stop. We'll stepwise walk this back as opposed to just making one fast incision through the area. Slow and steady wins the race. When we get done, you tend to always have somewhat of a classic diamond-shaped incision. As you cut it, it'll come up and back, and that's what you're looking for is the classic diamond-shaped incision. And you may have a little bleeding around the areas, and that is totally fine. These babies normally are crying when they're doing the procedure, and a crying baby is a healthy baby. And so that's one thing with working with infants. If they're not breathing and not crying, that is not good. If they're crying, then they are healthy and they are doing okay. When we lift them up, we would anticipate for them to quickly stop crying as we're holding them, and their heart rate and blood pressure to go back down and the bleeding to stop. Okay. And that's normally how that always goes if we're having a little bleeding. Let's look at this case because this is quite a tricky one. We used to use these little rulers for a while, but they kind of made it a little hard it was trying to standardize the elevation, and they just didn't work quite as well as you'd like for them to. But this was a picture from that time. But I love this case because when you look at this, like we said, we're looking for the anatomy. And in the middle of this attachment, you can see those salivary glands. It's tongue, salivary glands, more frenum attachment underneath it. So that frenum is actually that salivary glands living in the middle of the frenum. So you have to make your incision superior to those salivary glands, or you'll cut right through the salivary glands. Salivary glands don't bleed, okay? So you won't always know that, oh my gosh, I've cut through them. So you definitely want to make sure you're keeping your salivary glands in mind as you are making your posterior release, okay? And so this is what it looked like immediately afterwards. And so this is a very, very clean release. We're able to see that you've got nice margins here that aren't white and necrotic. They're not black and burned. It's a nice, clean incision. Okay. This is another wild frenum here because what we're looking at is this patient had so much tension on the floor of the mouth. And you can see it's like, how many frenums does this child have in the floor of the mouth? Well, it's all one, but it's all that fascia, as Nikki Mills taught us. That's the skirt fascia, guys, that is pulling that down onto the floor of the mouth. This is that classic V-shaped nasal, can't breathe through their nose, large tonsils. So this is a great team approach case where we're going to need to probably have this child over to the ENT to evaluate for tonsil and adenoid removal. We're going to need to have this child working with a orthodontist with some expanders and things. We probably need to work with an allergist to make sure we can get the decongestion and the nasal passageway clean, clear, and healthy. So this is not a tongue tie fixes all sort of case, but this is definitely more of your comprehensive approach. But you can see clearly what a struggle that frenum attachment is before the procedure, how excellent the elevation is after the procedure, and then in a week later, how nicely this has healed and how better of a control this child has. And so working with a multifunctional team can really help these kids have the best successes. Here's another really good infant case. And this is one where I would say working with a lactation consultant and advocating for the parent can really be a positive thing here. This mom had been an established patient with her other children in our practice, and she'd breastfed an older baby without any issues, and she knew instantly there was an issue with this. But the pediatrician didn't really mention too many concerns, even though mom was having severe feeding issues. The lactation consultant that they'd worked with in the hospital had mentioned concerns, but really didn't the mom just felt that it wasn't going well. The baby's not eating right. The baby's very fussy. The baby's struggling with latching. It's a very shallow latch. It's very painful. She wasn't experiencing this with her others. And she comes to us for an evaluation because she just felt like this wasn't right. And this is a classic anterior attached tongue tie. We release that tongue. The mom latches the baby, and instantly she's crying tears of joy because this is what she knew it should have felt like all along. And this is really that triad of what we're looking at here, where we have to look at what the mom is working with and the baby. So it's that the infant mother dyad that we have to make sure that we're taking into consideration, because severe nipple pain with an anterior attached to the tongue should definitely be something that we should be advocating for our lactation consultants and our primary care providers to be looking for and to help these babies get that care. Kind of back to this classic case here. I just love this one because it really shows us that we do need to take good before pictures, good after treatment pictures, and good 1 week follow-up pictures. I love a 1 week follow-up because it really helps us see how it's healing. If we're not having good healing at 1 week, we can go back in and make some adjustments to our post-op kind of care as far as elevation exercises and stretches goes, or we can make a little revision to the incision healing side too. So a good 1 week follow-up is a great way for you to make sure you're providing the best care you can for your patients and that they're on the healing track as well. Okay. Take those pictures, guys. Okay. Here's one other infant case where this is an immediate post-op. Look how nice and clean that looks. And this is 1 week afterwards. You tend to have a yellow, white, tan scab that is still persistent at 1 week and tends to go away at around week 2 to 3. With other lasers, it's 3 to 4 weeks. Here's another great case. I really like this one on an older kid where you can see that kind of cupping of the tongue. You can see how short that attachment is. After the release, immediately afterwards, the salivary glands are resting downward. The tongue is able to have wonderful control moving upward, and the patient is able to extend it out excellently. 1 week follow-up for this patient, you're still having excellent elevation, excellent extension at 1 week, and that's what you're wanting to see at a 1 week follow-up. So a beautiful exercise is there for that patient, a great success for them. I love Maya Angelou. When I think of lasers, I think of Maya Angelou, and I know that sounds crazy, but work with me here. Because we are all trained to do the best we can be, to be the best doctor we can be. You're on this webinar right now listening to this lecture because you want to be the best doctor you can be for your patient. Because we do the best we can until we can do better. And when we know better, we do better. We now know that there are better ways to do things than there were when we first started these. The scalpel is okay, but there's a better way. The diode is okay, but there's a better way. The all tissue laser, the Waterlase Erbium YSGG laser, is an excellent piece of equipment that can really help you have excellent control over the soft tissue and your surgical site to get you the best results you can. Is excellent for the patient because it really reduces the effects on that tissue because it's having less necrosis, less inflammation, less issues on that tissue cell level that relates to less scar tissue formation, less pain, less bleeding. So it's a win for you, the doctor. It's a win for the patient themselves. And if we can have a win-win, that is success every day. You'll notice at the bottom of my slides, I put learn, do, serve, because I believe we never stop learning so that we can do good and we can better serve our patients and our communities. Winston Churchill also teaches us that we will make a living by what we get, but we will make a life by what we give. I truly feel like this procedure is a way that we are giving back to our East Texas community, and we're serving those children and those families there in ways that other providers are not. And we are able to really fill a need. We see a need, we fill a need, and it is a great way that you can help serve your patients in your community. I'll leave you with this baby here. Once again, this was that one we started with, the one that was just days away from the ICU, that was having borderline failure to thrive, really struggling. This baby is now this child on the left. She is now 4 years old, and she is flourishing. This is her at a little beauty pageant that we were at, and her older sister won the Little Miss Bluebird pageant there. And so their family lives in my community. My daughter is friends with this little girl now. How ironic is that? So those are precious ways that we can help not just save a baby from a hospital visit, not just save families a lot of heartache, but we can help our communities. BioLace has just released some great new educational information that you can find on their website. You can also scan this QR code down in the bottom of your screen here, where you can have a step-by-step guide that they have put together for you that can help your office excel with lasers and also excel at standing out amongst the other offices in your communities, in your areas too, where laser procedures are involved. So go visit the website, go look at that, and also go see the other educational things that BioLace has going on. I'm excited to see where these new things are taking us, and always excited for the leadership that BioLace provides in our dental laser communities. If you want to follow me on social media, I post cases on there, and it is me that runs my social media account. So you can direct message me on there, and I will get back to you on my Instagram and my Facebook, or you can email me, and I'll be happy to respond. Probably easier to get to me on social media, to be honest. I get a lot of emails. Okay. Well, that concludes our lecture. We will open it up to any sort of questions that we may have. We do have some time for some Q&A, and you can put those into the chat box if you have those.
Awesome. Thank you, Dr. Curtis. And yes, please type in those questions if you have anything for Dr. Curtis.
With each of my lectures, I try to refine it based upon the questions that you ask at the end, so that I try to include that in my next one. So if you've got any burning questions, just know you might not be the only one with that, and you might be helping someone in my next lecture as well.
Oh, here we go. We have one, Dr. Curtis. Do you use nitrous while you performing the tongue tie laser?
That's a great question. Yes, yes, I do. Our nitrous in our offices all have the scavenging system, so it goes in and out, so it's not an open system like they do have in operating rooms and things like that. And so it's a little bit more of a closed system type thing, and so it is safe to utilize a laser with nitrous. We do get that question quite a bit, and so I do utilize it on procedures where I am utilizing nitrous. Good question.
Anyone else? What type of follow-up do you do or provide to the parents?
Great question, too. I love when parents are already working with other healthcare providers. And what I mean by that, if it's an infant and you're coming to me for a feeding problem, I want you to be working with a lactation consultant. So even if the pediatrician referred you to me, I will give you a card for a lactation consultant. I have some wonderful lactation consultants that I work with and feel so fortunate that are in my rural East Texas area that do home visits. And I mean, they will travel to these families to help them. And so reaching out to lactation consultants and all in your area and giving cards to the patients that come to you is a great way for follow-up, where you can make sure that that child is getting the best success. I always tell parents that I do a 1 week follow up, but I am like your knee surgeon, not your physical therapist. To have the best straight path for success, we want to be working with the therapists that can help us the most. So for infants, a lot of times that's going to be a lactation consultant. We also have chiropractors, craniosacral therapists, and even physical therapists that we work with as well in our community. One of my favorites is our physical therapists. They are kind of a niche infant young child physical therapist, and they work so much with these babies that are just weak as water to help strengthen those muscles up, to help them suck and swallow better. And so we can come alongside them to help them. For our older children, I love for them to be working with a myofunctional therapist or with a speech therapist, depending on what the struggles are that they're coming in with. Once again, that really helps their path to be straighter for success there. As far as in our office, our follow-up regimen is normally 1 week for infants, 1 to 2 weeks for our older children. What I like to see at those follow-ups is not perfection, but progress. That's what I tell the parents every time. I don't expect for you to miraculously have all the symptomatic improvements in the world or to have all the functional improvements in the world in that short amount of time, but we should be seeing progress. And I want to lay my eyes on that surgical site to make sure that the anatomy is healing how I want it to, that you're not having the reattachment or the scar tissue that is forming. And that if you are, we can go and make adjustments to that at the time. And so a 1 week follow up for infants is really great. I love it more than 2 weeks. 2 weeks sometimes is a little too long. And if you're having that more tight healing area, it's not as easy to go in and make an adjustment to the area. Okay. Good question.
Do you have parents hold their kids, or will you have your assistants help you?
Great question as well. This is totally up to practitioner preference, but what I do in my office, there are only two procedures that parents are not allowed back in the room for: IV sedations and infant frenectomies. Everything else, the parents are allowed back for. The reason I don't let them back for the infant frenectomy is they cry every time. And they don't listen to anything I have to say. They're very emotional. And I understand that as a parent. I've got 4 kids, and I'll tell you, I wouldn't want to be in the room for it. Not because it's a barbaric procedure, not at all. It's actually very minimally invasive, very quick, but I wouldn't want to have to hold my kid like that. And I have a lot of parents that have had the procedure done at other offices for other kids that say they're so thankful they didn't have to hold their child for that, that say they're thankful that we're just going to take care of the kid and they don't have to be in there. They definitely would come back if that was offered. My wife went back for my son's circumcision because the nurse just brought her back. And she's like, I didn't know, but I guess I was happy I was there for it. I was just unsure. It was terrible. But I was there for it. And so definitely those are things where I think it's just easier for me to be able to separate mom from baby and for them to see that I'm holding that baby, I'm loving that baby, and the baby's not crying. The baby leaves with me happy. The baby comes back to them happy. I take the baby away and tell them the baby will be away from them less than 5 minutes. I sit down with my assistant in our treatment room. I lay the baby back in my lap. I lift the tongue up, release the tongue with a laser, snap a picture of it, give the infant back to the mom. Back to the assistant. I go right into the consult room where the parent is, show them the picture of what the procedure area looks like. I found out very quickly that if they see it there, they'll understand so much more than when they get home and they're seeing it later. It makes so much more sense to them what's happening and what you're asking them to do with post-op care if they see it on the picture. It's not like it's their child, but it is their child. If you're trying to explain it on their child as the child is crying, they're not listening. They're just wishing you would get their baby up and make their baby stop crying. It's really hard for them to concentrate. But when the baby's not there, it's way easier for them to concentrate. They can ask questions and we can answer them so much easier. Then the baby comes right back in. The baby's not crying. The baby's fine. And the baby can nurse. That's almost 95% of babies right there in our practice. That's how it normally rolls. Good question.
Can you please provide the components of the compound topical you use?
Yes, I sure can. Okay, let's hold on. I'm gonna go for a wild ride here. Okay, there it is. Can you see them? It's 20% lidocaine, 4% tetracaine, and 2% phenylephrine. You just give that to any pharmacy and you ask them to make you a compounded topical of that, and they can. Mine comes in like this weird cosmetic jar. It looks like something that you'd have like face cream in. That's what they make it up in. Sometimes they'll make it up in a giant syringe too. But I like it when they make it in the jars. It's just easier to use, and any compounding pharmacy can easily make that for you. The time effect of that. The best topical ever lasts a long time. Okay. I was at a trade show once, and my buddy's dad, the one in the picture I showed you, his dad's an endodontist, and he made us try it and he swabbed it in our mouths and he laughed so hard. I couldn't, like, hours later, I was trying to drink water and I couldn't even feel the water go down, because we of course ate it because we're on a sales floor. So it was actually comical. So a little bit goes a long way, y'all, with these compounded topicals. Okay, with the lidocaine, tetracaine, phenylephrine, it's about 15 minutes that it normally lasts afterwards. But you want to wipe the tissue, apply it, and cover it up. Okay. Don't smear it everywhere. Okay. Because it will numb everything in soft tissue world. Okay. And if you leave it on there too long, you're definitely going to get a little bit of sloughing of the tissue. And that's okay. It'll just turn over and be better. But you just kind of have to be conscious of that too. It's pretty potent. Other questions? These are all great, guys.
Yeah, great questions.
And I would say too, if you're going to be doing like a frenectomy, you could definitely use like the best topical ever, wipe off the frenum tissue, put that on and cover it back up and just hold it there and leave it for a minute or two. Then you can take it off, lift the tongue up, and release straight through it. Sometimes once you've gotten halfway through, it might not have penetrated all the way, and you might feel the patient squirm a little bit. You can wipe the area off, put a little bit more of the topical on, cover it up for just a little bit, and then go again. That's totally fine. Or, like I said, you can just do the topical, inject straight into it with a little bit of. You don't win a trophy if you didn't pick up a syringe, okay? So you don't get a gold star for that. So a little bit of topical and a little bit of local goes a long way to keep them comfortable. For those of us that want to get into lip and tongue type treatments, what is your recommendation? Great question. Okay. So there are many different educational resources that you have. On the Biolase website, there should be a plethora of lectures and all that you can go back and see and look at. Biolase does have a frenectomy course that is offered, I believe, by Dr. Jaju out of Virginia. That is kind of you could travel to her office and she does that. In the past, we have had conferences by a Biolase called Tequila and Tongue Tie that were fun classes, were fun conferences as well, where we learned about tongue ties and those procedures as well. There's other courses out there that are offered by Richard Baxter. That's a great resource as well. He offers online courses as well as also in-person ones as well too that are excellent there. Another question, this may be the last one we have time for. Do parents of infants need to do any manual stretches or massage? Yes. Okay. Great. So for infants, you definitely want to make sure that you're sending them home with post-op stretches. I like to call them exercises because stretches sound easy. Their exercising is not easy, and these are not easy. And I tell the parent that I used to sugarcoat it, but then I was like, no, these parents need to know. I have them do exercises for 6 weeks, y'all. Okay. It's 3 weeks to get the outer layer to heal and then 3 weeks for the inner layer to heal. You've got to get that inner fascia to be stretchy as well. So you want to do those exercises. Okay. I have the parents lift that tongue up and back, up and back, up and back, 6 lifts 6 times a day for 6 weeks. Just remember the number 6. Okay. And that's pretty standard across the board for what our lactation consultants are recommending as well. You can get into some pretty fancy type of exercises as well and stretches and stuff. I leave that up to our physical therapists, our lactation consultants, our craniosacral and chiropractors to kind of walk them through that if there's specific things that they want. I just try to keep it simple for them. For our older children, definitely working with speech therapists or myofunctional therapists so they can have proper training and suction of the tongue to the roof of the mouth, tongue up, lips closed, healthy breathing through their nose. Thank you, Dr. Zoggy. That really helps us with the older children. I think that's about all the time we got.
Yeah, thank you everyone for joining us. And if anyone is planning to attend the AAPD in Las Vegas, please stop by and say hello at our BioLace booth. It is booth number 1009. So if you happen to join or happen to stop by, say hello. Thank you everyone for joining us. Thank you, Dr. Curtis, for this awesome lecture. And if anyone has any questions, you all have my email. My name is Javier Gutierrez, calling from Biolase. And that is all for today. Everyone have a great evening.
Thanks, guys.